Hey, welcome back to the LeBauer Show. So, right now, what I want to do is talk about the number one thing most physical therapists get wrong, and exactly how you can make sure patients know that you are the right person to see for their problem. So, my name is Dr. LeBauer. If you're listening to this, you've probably listened to other episodes. But when I was a massage therapist first, and then I went to PT school, and then I started cash practice, and I became a business coach. When I was a massage therapist, I loved working as a massage therapist. One of the most frustrating things is people would say to me, it was frustrating and complimentary. People would say, Aaron, you're the first person to ever touch me where I hurt. You're the first person that's actually ever helped me. I've been to see other massage therapists, chiropractors, physical therapists. I've been to the orthopedic surgeons. I've had the injections, had the surgery, and no one's ever touched me there. And that's exactly where it hurts. I've just been waiting for someone to do that. And I was like, after a while, I was like, okay, cool, great. Like, cool, that's why people pay me $85 an hour. And that was in early 2000s. It was 20-something years ago. People pay me $85 an hour. And the sad thing is PTs right now are making less than $85 an hour. Look, I didn't have a job, and if you're making $50 an hour, you're working in a job. But I also had 4 to 5 patients a day, and I had a lot of freedom doing it, and I had a lot of ups and downs. So there's a trade-off. But at the same time, I was making $85 an hour as lowly Aaron, the massage therapist. Yes, I graduated from Duke, but massage therapy is a certificate program. Wasn't even licensed in California because you didn't need to be. But people were still saying, I've been to see all these medical professionals, and you're the first person to touch me where I hurt. So what I want to do today is, without sitting you in a room, sitting you on my table, putting my hands on you, try to give you these insights as to how we help patients and the 3-part framework that we use in our clinic and that I use to help our patients get a treatment and experience they can't get anywhere else, but also help our therapists create an experience that's very similar, even if they have a different treatment philosophy. So here's the number one thing most physical therapists get wrong when treating patients: that you just don't touch patients. You're not touching them. And you might not be a manual therapist. You might be manual therapy's hogwash. Well, if you are a manual therapy's hogwash type of person, you're probably not listening to my show because I don't really resonate with a lot of those guys. But you know what? Maybe you are, maybe you do. And maybe you're like, ooh, whoa, Aaron's a manual therapist? Yeah, I was a massage therapist. I studied MFR with John Barnes. And I've done trigger point therapy well before I did dry needling. And one of the really cool reasons I liked dry needling with Jan Damerholt, in my opinion, was that he's teaching dry needling through the philosophy of Janet Travell. And Janet Travell is whose books we used when I was in massage therapy school as part of our, I think you call it like neuromuscular therapy massage. Maybe nowadays they call it more of like a medical massage. It was trigger point therapy. And I get to dry needling. I'm like, wait a minute, I already know all this stuff. Not only that I was a PT, but I know where the trigger points are. I just had to learn how to put the needles in, what that technique was, and the contraindications, and where and how to do it. I didn't have to learn anything about the trigger points. I had done it a long time. But most people are not getting touched. And here's why this is a problem. It's because you come in, I'm playing with my pen fidget. Most people come into a clinic and they're sat on a bike. They get some ice packs. They run through some exercises. They've just never even been touched. I learned this from one of my clinical mentors, Bob Duvall. We have to meet our patients' affective needs, affective needs. And what that means is they need to feel confident that we know exactly where the problem is. And one of the ways to do that is to touch them where they hurt. We have to touch patients where they're hurt, even if we don't really believe that people need more than 30 to 45 seconds of hands-on care, which is what my professor said when I was at PT school in Elon. And she said that, and I raised my hand right away. I was like, I didn't even wait for her to call me. I was like, I just have to say that I want to make sure everyone else in this room knows that I made my career as a massage therapist, because that's the way PTs think. Oh, Debbie was mad. I could see it in her face, but I could not let the other 40 people in class think that was the way it was, because that's how I built my business, was people were not being touched in PT. So here's what I'm saying is people are going to orthopedic surgeons, PTs, etc. And look, I'm hitting the trigger point in their traps, their infraspinatus, their quadratus lumborum, their piriformis, gastrocnemius. These aren't hard to reach places. These aren't like crazy, like, oh my God, like Aaron's deep in a psoas or something in a diaphragm or who knows what, like, working on the high. I mean, I'm not like working on someone's hyoid and doing the, like, even the pterygoids, like that's hard to get to once you figure it out. It's easy, but we're not even talking about that. We're talking like simple, easy, temporalis. That ain't hard to touch. Someone's like, I pain in my face. Well, you have to know a little bit about trigger point therapy, but you just have to use your hands and explore. So here's how you do it. Here's how you touch someone where they hurt. You say, hey, point to where it hurts. They point. Okay. What does it feel like? Great. Let me take a look at you. You put them on the table or in a massage chair, even they can sit on a couch, and you just kind of gently rub your hands into their muscle, and you're just feeling to engage the muscle. Like, it's really hard to say in words without showing you my hands, but if you're a physical therapist, you've done some of that. And what you say to the patient is this. You say, hey, I want you to let me know when I hit the right spot. Like, let me know if like I hit a spot that takes away the pain or it makes it worse, or even it's just like, oh my God, that's it. Like, just let me know. Because if you're right on a trigger point, if someone's on a trigger point, I'm like, oh my God, oh, that's it. Like, you're right on it. But it can't be super light touch and it can't be forceful. What we want to do is match what their body, our patient, our client's body is giving us. We need to match it. Match it with the pressure, not over pressure and over force it. It's more of, can we meet their body where it is? And then treatment is, to me, really easy. Oh, I found the spot. Okay, cool. Take some deep breaths. Breathe right into it and see if you can soften. And I'll just let them soften. And a lot of times just finding the trigger point helps deactivate it a little bit. And you can argue with me on trigger point theory or not. I don't really care. Like, that's not why we're here. And side note, people are like, Aaron, how do you know that what you do works? I'm like, well, I don't know. People pay me $250 an hour for me to do it. I'm pretty sure that means it works. And why are they dropping out of, traditional physical therapy? Why are there all these apps built, to increase compliance in traditional in-network practices? Because you don't have time to touch people where they hurt. You're not meeting their affective needs. You're not doing anything that they feel is helpful because you probably don't have the time. It might not be that you're a bad therapist, just the model, you don't have the time. So you kind of have all these things to keep them compliant, it creates some skepticism. But that's it. It's just, you kind of explore and find out. You don't even have to know trigger point therapy. Point to where it hurts. Okay. And then you just press around, push, press, soft. Use your hands, use your energy. Use like wide, flat, firm hands, pressure, and touch. And then you can take your thumbs, your elbows, your fingers, and just explore the muscles and see, is there a tender, tight spot that gets that patient to be like, ooh, twitch or move or go, oh. And what you have to do is just give them permission to communicate with you that you're in the right spot. Or say, hey, tell me, is it higher or lower? Because they'll be like, oh, I feel like you're close to it. Just go down, left, right. And just don't be afraid to explore with your hands. That's what we learned in massage therapy school. They did not teach us in PT school. So this is what most physical therapists are getting wrong. Most providers are getting wrong, is that you're not touching your patients. I mean, straight up. You're not touching your patients where they hurt. When you can touch your patient where they hurt, they will know, he gets me. He understands my body. He knows where my problem is. They'll still question whether it's, right, or like the root. They'll still get to this point where they're like, I need to know the root cause of the problem because you and I don't have x-ray vision, because they're impatient with the process, because healing is a process, not an event. And we have to get that across to patients as well, because they think, oh, he's found it. Great. Why isn't it gone? Well, this takes time. Oh, I need to get the MRI and some surgery and it'll be gone. They promise it'll be gone right away, which we all know that that's bogus. So there's still these expectations. If we can meet their affective needs and get them to know that we understand, and we can repeat back to them what they've told us and help them in a way, test, retest, like move in a way that makes it hurt, press on them, move in a way and be like, oh, it feels better. Great. Like, imagine the results we'll get if we actually get you through a plan of care. Or maybe it makes it worse. Okay, great. Like, this just means that, it's a different dosage, or maybe the problem's somewhere else and I need to run you through a full evaluation. Maybe it does nothing. Okay, so maybe it's a referred pain from, I don't know, an internal organ, kidney stones. Okay, but we'll know that after a few visits because of the patterns we recognize. But if you can't touch them exactly where they're hurt, that doesn't mean you can't help either. And sometimes pain is not related to a muscle or a joint, and it's more diffuse. And there's other things there. But if we can change people's experience, we can provide some input to their body and to their system to change what they're feeling, good, bad, I know that we're in the right place. Maybe there's cases where we need to bring another provider in or get a second opinion. But I know if I can change your pain, your mobility, your experience, like I can help you. And if I can't help you, maybe I'm looking in the wrong spot. And that's really where I need some time to look and see, oh gosh, even though their pain is in their neck and their head, there's a referral from somewhere in the thoracic spine. Maybe thoracic rotation's locked up. I need to do some MOBs, but I need to test it first. Okay, so here's why cash practices are better than in-network clinics. This is the only reason. This is maybe the bonus, but there's one more piece. This is why it's better. Guess what? I have the time to explore and find out, and I am under no pressure to do a quick manipulation and quick exercise and move on to the next person. I don't have that pressure. And maybe some of you are in network clinics where you see one person one-on-one for a half hour. Okay, imagine if you had an hour. Okay, maybe you see people one-on-one and you still see 4 people an hour and it's great and you get great results. Cool. There's a subset of people that won't be served by that. And that's the subset that comes to me for sure. Okay, that's not only people that come to me. But in a cash practice, we have basically unlimited time to figure out what's wrong with our patients. If I tell a patient that I don't agree with what your physician said, this is what I see and this is what we're doing, like there's no reciprocation. Like I'm not worried about them not reciprocating, like never referring to me again because I disagreed with the orthopedic surgeon. Okay, but if you are an employee and you're getting patients better faster, you might get reprimanded like Tyler did. Or maybe you own the in-network clinic and you disagree with the surgeon and you have to tread carefully because if patient tells the surgeon, it gets back to them, they stop sending you, 10 people a week. Well, that's limiting your ability to help your patients. That's to me why cash practice is better, but really it allows me to get to the root cause of the problem and touch patients where they hurt. And so here's the framework. I'm going to finish with the framework that I use in my clinic, and feel free to use this in yours. Just if you teach it to someone else, let them know where you learned it from. But the framework that I use with Derek, Tyler, Caitlin, Chris, who are the physical therapists that have worked for me, is this. It's listen, touch, and empower. Okay? Now, what I do for my employees is I do train them myself. I send them to an MFR course, a dry needling course, and SFMA. And with those 3 starting skill sets, we treat patients in this framework. We listen to our patients when they come in, and at the beginning of every visit, we ask specific questions. We're not asking, how are you feeling today? We're not asking, do you still hurt? Yes or no. What's the rating your pain? So we listen to them. We get feedback from them. We acknowledge them. They know that we know where the problem is. We use active listening techniques. We touch them where they hurt. And every visit they get touched. Even if it's just as part of the evaluation, or maybe it's only a handshake. I've had some patients not really want manual therapy. It's fine. I had one patient who really wasn't into it, and we just did education and lifestyle changes, some exercise, and he still got better. Yeah, but that's very rare. So we touch our patients, at least 15 minutes of some hands-on therapy. At the very least, do a suboccipital release. People go, what are you doing? You just say, hey, close your eyes, take 5 deep breaths, and in 3 minutes, in 5 minutes, tell me what I did. And then we empower our patients. We always give our patients 1 or 2 exercises to take home with them, not a ton, just 1 or 2 that change their symptoms, help them get better, and help them feel in control of what's going on, right? Because it's not my job to keep patients forever. I want to empower them to take control of their own health. That's why we work with patients who want to take control of their own health, people that want us to just passively do to them and fix them and without doing any work. They're not really our patients and they don't get the results because they're not doing the work. Same with my coaching clients. You gotta want to take control and take action, right? Listen, touch, empower. That's what we do. Every visit, there's something that we empower them, we educate them, we give them tools to feel more in control of their health versus having their choice taken away by a surgeon saying, we can always do surgery. Surgery is just routine surgery. And people get scared shitless out of it. And hearing that just always bugs me. So, just to wrap this up, touch your patients. If you need a good course to learn how to touch patients, there are a bunch of them out there. And it's not just manips and pivums and pavums, soft tissue. Go take a massage therapy course. Go do like trigger point therapy. Don't just needle people. Touch their skin to skin. Get in there. You're a physical therapist. Darn it. If you're just an exercise-only physical therapist, cool. If someone hurts somewhere, press on it and be like, is this it? Yeah, okay, great. Take a couple deep breaths, turn your head left and right. Even just do it as the evaluation, then get your exercises in. But don't be so like, I can't touch people. I've touched naked people. I've worked on a lot of naked people. They had a sheet over them, but, get over that part. I don't know why people don't want to touch people, because patients love it. People will just sometimes just pay you to be touched, because people are deprived of touch in their life, in their daily life. It's one of the most beautiful gifts we can give someone is compassionate touch. At the very least, if you work in a hospital, get a new pair of socks, take it to your patient, put them on there, and give them a little 5-minute foot massage. No matter how stinky their feet are, then go wash your hands, get over the smell. Because I think that more people in hospitals need to be touched. People that are dying need to be touched. People that are living are probably dying inside because they're not getting the touch. And if you're that person to give them some compassionate touch, oh my God, they'll pay for it. They will. They do. I've had that experience. I've paid for it. I've been touched by hundreds of people. I've touched probably thousands of people. Touch is really powerful, and if you're not using it in your practice, you're missing out. And if you're not using it as much as you think you could, go take some courses, get some opportunities to be more, go get some body work yourself. Be more in touch with touching people and touch them, because people love it. And that's it for today. I'll see you on the next episode.